Attention deficit hyperactivity disorder is widely misunderstood as a strictly childhood issue. The National Institutes of Health classifies ADHD as a developmental disorder that persists well into adulthood for millions of people. The adult symptoms fall into three specific categories. First is inattention. This means struggling to stay on task, constantly getting distracted, and dealing with chronic, severe disorganization. Second is hyperactivity. While kids bounce off walls, adult hyperactivity manifests as an intense, constant internal restlessness or the inability to engage in quiet activities. The third is impulsivity. This shows up as acting without thinking, frequently interrupting others, or engaging in risky behaviors due to a struggle with self-control. When combined, these symptoms actively degrade your daily functioning. They disrupt your ability to perform at work, keep your home life stable, and maintain interpersonal relationships. But because medical guidelines require proof that these symptoms started before age 12, simply getting an accurate adult diagnosis is a massive, exhausting effort of hunting down childhood records and gathering past behavioral reports. This flowchart illustrates this. The exhausting adult diagnosis process leads directly to a new bottleneck: treatment paralysis. You must choose a management strategy: medication, therapy, coaching, or accommodations when executive function is lowest. We evaluate each by its executive function ROI, mental friction versus symptom relief. Effectively managing adult ADHD requires navigating this exact trade-off. You are balancing the need for immediate physiological relief against the difficult work of building long-term structural resilience. This comparison table outlines our options. We'll start with the first row, medication. This is the most common and direct intervention for adults. The input friction here is heavily front-loaded. You have to navigate the medical system, secure a psychiatric evaluation, and endure a trial and error period to find the correct dosage. The outcome is rapid. Stimulant and non-stimulant medications directly regulate your neurochemistry, offering an immediate, noticeable reduction in inattention and hyperactivity. But the trade-off is significant. Medication lowers the biological barrier to focus, but it does not dictate what you should focus on. It will not teach you time management or organizational skills. Medication provides the physiological foundation required to function. It gives you the necessary fuel, but it is not a complete structural solution for a disorganized life. The second pathway is psychotherapy, specifically cognitive behavioral therapy. The input cost for therapy is heavy. It takes a high, consistent investment of time, money, and mental energy to attend weekly sessions and actively practice new coping mechanisms. The outcome is a deep rewiring of your behavioral patterns and improved emotional regulation. Therapy is uniquely positioned to treat severe comorbidities. For example, up to 70% of adults with ADHD suffer from sleep problems, which therapy can directly address. The trade-off is that the return on investment is extremely slow, and early dropout rates are high. Therapy is highly effective for long-term emotional stability. However, if you are entirely unmedicated and currently overwhelmed by daily tasks, you likely won't have the bandwidth to participate. The third pathway is ADHD coaching and lifestyle design, aimed at managing daily chaos. The friction here involves the out-of-pocket financial expense of hiring a coach and the immense upfront willpower required to self-impose rigorous schedule changes, like mandated exercise routines. The outcome is the direct acquisition of practical executive function skills. You learn exactly how to plan, how to prioritize, and how to actually use a calendar effectively. The trade-off requires sacrificing immediate, easy dopamine rewards for the sake of future stability and routine. While this pathway requires the highest degree of self-discipline to start, it builds the actual daily scaffolding that the ADHD brain lacks naturally. The final pathway is workplace accommodations. This is a structural change to your environment rather than to yourself. This intervention is grounded in the legal protections provided by the Americans with Disabilities Act. You have a protected right to request reasonable modifications to your job. The upfront friction involves navigating bureaucratic HR paperwork and taking the vulnerable step of disclosing a psychiatric diagnosis to your employer. The outcome is a modified environment that fits your brain. Securing quiet workspaces or flexible hours drastically reduces occupational friction. The trade-off is the social risk of workplace stigma and the fact that accommodations offer absolutely no symptom relief once you clock out and go home. Accommodations are a powerful shield for protecting your career, but they do not resolve the underlying neurology. This decision tree maps out the deployment sequence. No one should attempt all 4 methods simultaneously. You must use high-speed interventions to gain the bandwidth needed to build your slow-moving systems. If you are in crisis or facing severe daily impairment across all areas of life, prioritize medication first. You need to stabilize your physiological baseline before you can do anything else. If your primary friction is strictly occupational, failing to keep a job or consistently missing deadlines, prioritize ADA accommodations and ADHD coaching to restructure your working environment. If your symptoms are managed at work, but your personal life and relationships are fraying, prioritize psychotherapy to address emotional dysregulation and comorbidities like sleep loss. Managing adult ADHD is not a search for a cure. It is a sequenced investment strategy. Build the physiological foundation first, and then use that stability to actively engineer the environment around you.